Ohio State University and also the director of the Thoracic Oncology Center as well. And he'll be talking about the advances in small cell lung cancer.
Okay, thank you, Ravi. And even worse than mesothelioma, small cell, up until this year, actually up until now, is treated exactly the same as I was taught 25 years ago as a fellow. So I did have a little bit of trouble coming up with 5, so it's really 4 with 2 immunotherapies. Oops. So the first study I'd like to talk about is the Pembro and extensive stage small cell that was reported by Dr. Ott. And this was patients that with small cell lung cancer after failure or inability to receive standard therapy, good performance status, got Pembro, and they were also specifically required to have PD-L1 positivity. So the one interesting fact in this study was that the PD-L1 is difficult to get in small cell, as for obvious reasons. For 157 patients, they tried to get PD-L1. They only ended up with 42 PD-L1 positives, so 28% were PD-L1 positives, but they had a large number of drop-offs in this study. But the fact is that they had a really good waterfall plot shown here. And the spider plots showed that these responses were durable. And in this figure, they had 6-month data. And also in ASCO, Scott Antonio presented Checkmate 032, which looked at the combination of Nivo with or without IPI in small cell, and we don't need to go through this, but they work different points in the immune induction. So this was one of these complex trials that had multiple dosing regimens as well as multiple combinations, and he reported on the Nivo 3Q2, Nivo IPI 1 and 1, or Nivo IPI 1 and 3. So these patients had these characteristics, but importantly, they had a very high fraction of platinum resistant or refractory patients in this study. And again, they saw significant objective response rates in this, in both the Nivo alone and the IPI-Nivo. But interestingly, in the footnote here, they said that there were additional patients that had a PR after the database lock, so that in the combo trial, the final overall response rate was 32%. And again, the spider plots look very impressive for this refractory disease. And in this study, they were not selected for PD-L1. And so this shows the waterfall plots for the Nivo and the IPI-Nivo treatments color-coded for less than 1% PD-L1 or greater than 1% PD-L1. And you can see that even the less than 1% PD-L1s were some of the best responders in both arms, suggesting that in small cell, the PD-L1 may not be an important marker. And this is the overall survival. So also importantly, as you might expect, the toxicities, grade 3-4 toxicities were about double in the IPI-Nivo arm. And one patient had an irreversible grade 4 limbic encephalitis. Not a good thing to have. So The next advance I'd like to talk about is a really completely new type of therapy, a DLL3 targeted antibody drug conjugate that was presented recently. So this notch has got multiple ligands and DLL3 and multiple receptors, and the DLL3 is the one that they're studying, they've determined here. And it's expressed on the surface of small cell lung cancer tumor cells. This is just shows 3 different ligands, and it's the DLL3 that is expressed. And that the expression level is quite high in large cell neuroendocrines, naive small cells, and relapsed refractory small cells. And so this drug was designed, which links a antibody, SC16, to a chemotherapy, the drug they call D6.5. It's published recently in Science Translational Medicine. And so they developed, and they showed efficacy in vitro, looking at a distribution of expression in small cell PDXs. If you take a high expressing PDX, the antibody drug conjugate is incredibly effective. If you take one of the medium expressing PDXs, it has activity, but it's less effective. And if you take one of the 0 expressing, it has no activity, consistent with mechanism of action. So this trial was reported at World Lung, and it showed a very impressive waterfall plot in second and third line patients with high response rates, 40% or so, in the 80 patient phase 2. So I think that that's an impressive and promising new therapy. Another thing that has recently come out in small cell is the ability to capture a large number of circulating tumor cells and establish CTC xenografts, CDXs, and these are just some examples. And the responses of the CDXs mimic that of the patient. This was the patient that had a long survival, and the CDX had a similar good response. Patient with a short survival had a very poor response in the CDX. They were able to genetically characterize these circulating tumor cells, and in fact, this is a principal component analysis, not fractals, that showed the correlation of the patient tumor with the CDX genetic analysis. So I think that this is a potentially important new development in improving our understanding of small cell lung cancer. And so the last thing I'd like to touch on is radiation therapy in small cell. I think it's very clear that the role of radiation therapy in small cell is expanding in spite of certain UK trials that say we shouldn't radiate people's brains at all ever. And there's trials looking at radiation therapy in extensive stage disease. There's SRS and oligometastatic disease. There's studies of PCI in extensive stage disease, combinations with immunotherapy. But I'd just like to show this one slide. Very recently, study published in Lancet of 500 extensive stage patients with any response to cisotopicide and residual intrathoracic disease, randomized to get thoracic radiation or not. And there was a statistically significant PFS difference and a highly statistically significant tail of the curve here with many more people alive at the 2-year time point. So I think that's another exciting avenue for research to improve the outcomes in this disease. So in summary, it's been a pretty good year for treatment of small cell after years of drought, but we still have a lot to do to improve the management of this disease. I'm very intrigued by this DLL3 antibody drug conjugate and immunotherapies. I'd like to see DLL3 used as a chimeric, a CAR T cell approach to. I don't know if they're planning to do that. I think CTC analysis is a terrific way to study the evolution of small cells in vivo in patients, and people are doing those kinds of studies, and I think radiation therapy really is optimization and using modern radiation therapy techniques in these patients can really have a significant impact on outcomes. So thank you.
Extensive stage and they radiated them or not, and they did better. But this one, I mean, now 500 patients, is that now your standard of care? I mean, are you going to, because again, there was data before, and that seems really very impressive.
I think, obviously, it's not a huge split of the curves, but you're turning. I think you're turning some of these extensive stage patients into effectively limited stage patients, and I was talking to before the meeting that fundamentally all small cells are metastatic.
Exactly.
You can't take it out and then just have the patient come back 5 years later. They'll all relapse. So the difference is in how good we are at detecting metastatic disease. And if we looked at CTCs in every patient, we might have no limited stage disease. And so the approach of adding radiation to those that respond well, I think, is very reasonable, and in fact we do it at our place. Usually not immediately. Usually we'll look to see if there's head avidity 3 months later, or a single spot that seems to start growing, and then we'll radiate it then. But we do have a study for oligo disease in small cells. So.
Short question. So in terms of the lack of association of PD-L1 expression and responsiveness, was that done just on tumor cells, or was it also including circulating T cells, which obviously can also express PD-L1?
Yeah,
was that analysis done?
All these studies are done with tumor cells.
Yeah. So
and I think it's unclear. In fact, all of the big studies use tumor infiltrating cell analyses. I'm not aware of, has somebody carefully looked at large numbers of patients for PD-L1 in circulating T cells?
It's clearly that it's on a lot of other cells.
Well, I know
besides
it's
just
there,
tumor.
but is that correlated with outcomes?
No, I'm asking you.
No, I have no idea. So we're doing a neoadjuvant study that's looking at it in draining lymph nodes too, and maybe there it's relevant. Okay?
Thank you, Dave.